and novel approaches to TB infection control in healthcare setting. So this work is not about improving TB infection control in TB hospitals. So this work is about improving TB infection control in general private hospitals. That's why it's a kind of different and experience in terms of introducing TB infection control measures in general healthcare settings, at least in my country, was very limited before we've started this work. So the work was supported by USA Georgia Tuberculosis Prevention Project in collaboration with the National Center for Disease Control and Public Health, and I have no conflict of interest to declare in relation to this work. So Georgia is a small country, 3.7 million, and TB burden is quite high. We are not included in the high burden list, but still TB remains a major public health concern. And while we do recognize and the risk for TB transmission is very high among healthcare workers, and in hospital settings is a TB hospital or non-TB hospital. Here we do work on improving infection control practices, and you see FAST, and I'll explain in a minute what does FAST stand for. And of course, we do implement environmental control measures and also personal infection control measures. As for the FAST strategy, I don't know how many of you is familiar with the concept, but FAST has been introduced a few years ago within TB care too, and this stands for find TB cases actively, separating safely, and treating effectively. And it is applicable to healthcare settings, is at hospital settings or outpatient settings, and it intends to detect TB cases among unpresumptive population, like people who come to hospitals for other reasons, not for TB-related reasons. Here I would like to describe steps, what was done in terms of this fast implementation in healthcare settings in TB hospitals. So actually the first step is initial screening. When patient enters the hospitals, and a reception nurse or receptionist asks questions about, the discovery if the patient has any TB presumptive signs, so TB presumptive symptoms, and if this is positive, then they take sputum, and sputum gets tested for TB. And in our case, we use gene expert testing, and the project provided 2 gene experts for 2 selected private hospitals, and we could do that immediate on-site testing for every patient which were considered as a TB presumptive case. So what we found here, you can see on these diagrams that after active cough surveillance, we could have immediate access to gene expert testing, and we found over this period, 18 months period, we found almost 1,500 patients with presumptive TB symptoms, and they all were tested with gene expert, and out of those 12% were found with MTB positive, and 2% of those MTB positive were found with rifampicin resistance, and all these patients were from non-presumptive population, so people who go to health facilities with just different reasons not related to TB. And you can see here that FAST strategy contributed to 3.5% to national case finding efforts in 2016, meaning that it's very important to have some sort of mechanism, so very sensitive mechanism for finding TB cases in general healthcare settings, because in general, TB hospitals are already designed to identify and easily and accurately find TB cases, but general hospitals are not prepared for it. That's why it's important to sensitize them and to equip them with relevant tools how to quickly find TB cases, and most importantly, to link these cases to National TB Program for appropriate care. Here I have this diagram to show where does FAST fit into the overall quality framework, because, well, FAST is infection control strategy, but if you would look at this framework, FAST is about safety. It's very important strategy to improve safety in hospital environment, and it's a very important strategy to improve timeliness, so timely access to accurate diagnostic and treatment, which is critical for improving TB care outcomes. So what we've learned is that it's very important to have private providers sensitized about the importance of TB and have them equipped with sensitive and accurate diagnostic tools to diagnose TB cases in their environment. And based on this experience, we've then decided to roll out this pilot countrywide and have gene experts installed at general hospitals at a district level. So in general, of course, again, FAST is an infection control strategy, but it is very important to consider FAST in the context of quality improvement strategies and somehow try to integrate this approach into quality improvement, accreditation, certification system. So in countries like Georgia, there are no well-functional system for host facility accreditation, quality assurance, etc. So that's why it's very important to mobilize international accreditation community like Joint Commission International, and to advocate for including TB-related infection control in accreditation criteria. So this is actually very briefly what I wanted to share with you. If you would like me to clarify some aspects of it, or if you have questions, and if we have time, I would be happy to take these questions. Thank you.
We'll have time after fourth presentation. Okay. All together we'll respond to the questions a little bit later. So the next presenter is Dr. Agustin on the evaluation of TB infection control strategies in Philippines. Please.
Good afternoon, dear colleagues. I am Dr. Agustin from the Philippines. And on behalf of my co-authors, Dr. Berba and Dr. Lucero, I would like to thank everyone for giving us this opportunity to present here in the Union. Our study is entitled Evaluation of TB Infection Control Strategies in the University of the Philippines, Philippine General Hospital. So tuberculosis continues to be one of the world's deadliest infectious diseases, and in high prevalence, low-income countries like ours, national TB programs generally focus on early diagnosis and appropriate treatment by strengthening the TB services. Unfortunately, hospital infection control is frequently neglected, but it is imperative since healthcare workers and inpatients are at risk. A systematic review has shown that there is an increased risk for TB among healthcare workers, with increased prevalence and incidence of latent TB infection, and additionally, healthcare workers are approximately 6 times more likely to be hospitalized due to MDR-TB. In the setting of drug resistance and immunodeficiency, as exemplified by our patients with HIV/AIDS, there has been an increased risk of TB outbreaks within hospitals. In 2015, in our institution, there were 16 personnel who were diagnosed with and treated for pulmonary tuberculosis. While the source of transmission cannot be determined, the clustering of TB among healthcare workers in our institution alarmed us at the possible risk of ongoing transmission. And given this background, we aim to evaluate the existing TB infection control practices in our hospital with a descriptive study. So our specific objectives were the following: to describe the baseline demographic and clinical characteristics of our patients, to identify the current TB infection control measures in the hospital, and to assess the compliance to the 3-level hierarchy of controls recommended by the WHO and the CDC, to compare the intervals to diagnosis, treatment, and isolation, and identify the reasons for missed or delayed isolation, and to evaluate inpatient utilization of TB dots. So the Philippine General Hospital is a tertiary public training hospital with a total of 790 charity beds for adult inpatients distributed among different services. We have an HIV treatment hub and a cancer institute in the hospital. All adult inpatients admitted in the charity wards between April to August 2016 with bacteriologically confirmed PTB as identified by sputum AFB and gene expert were included in our study. A data collection tool intended to gather this data among inpatients was utilized during chart review And in particular, we were interested in the baseline characteristics, diagnosis interval, treatment interval, isolation interval, TB DOTS referral rates, and we compared this between different ward areas. We also did a data review from the Hospital Infection Control Committee, TB DOTS, University Health Service, and the Department of Laboratories. These data were collated and reviewed using the TB risk assessment worksheet given by the CDC. So out of 95 inpatients whom we initially included, there were only 72 inpatient records available, so they were included and analyzed in our study. Majority of our patients were male, aging 20 to 91 years with a mean age of 44 years, and the most common admitting diagnosis was still pulmonary, namely pneumonia. Most were admitted in the medicine wards. The top comorbidities were pulmonary, endocrine, renal, and cardiovascular in nature. 11.1% were previously treated for TB. The most common TB symptom present was chronic cough at 61.1%, and 61.1% had presumptive TB on admission, while 8.3% were already confirmed PTB cases, but with sputum studies obtained in order to determine infectiousness. PTB was not considered in 30.6% of patients upon admission. The mean diagnosis interval, defined as the time from admission to the bacteriologic confirmation of PTB, took 5.82 days with a standard deviation of 5.47. The mean treatment interval, defined as the time from bacteriologic confirmation to initiation of treatment, took 0.77 days with a standard deviation of 2.9. And the mean isolation interval, defined as the time from bacteriologic confirmation to actual patient isolation, took 8.23 days with a standard deviation of 6.37. The mean diagnosis interval was shortest for patients in the ER and longest for the patients in the surgical ward. And the mean treatment interval was shortest for patients in the medicine wards and longest for the patients in the surgical wards. The mean isolation interval was longest for the patients in the medicine wards. So only 59% of patients with confirmed PTB were actually isolated. 41% experienced isolation delays and failures due to 3 major reasons. So the first is the lack of vacant isolation rooms in the emergency room and the medicine wards. And the second was the lack of isolation rooms for the surgical wards. Ongoing cleaning or refurbishing also contributed to isolation failures in this study. As of this study, we only have 5 isolation rooms in the adult charity areas, 3 in the medicine wards, 1 in the medical ICU, and 1 in the emergency room. Treatment was initiated in 66.7% of patients with bacteriologically confirmed PTB, and only 55.6% of patients were referred to TB DOTS while still admitted. Using the CDC risk assessment worksheet, the following problems were identified. First, there is suboptimal adherence to existing hospital infection control policies among healthcare workers. So, among healthcare workers who are exposed to infectious TB patients, they are supposed to undergo baseline sputum examinations and X-ray immediately upon exposure and 3 months after exposure, but this is rarely being done. Second, the existing number and quality of isolation rooms are not enough for hospital inpatients with TB, and there is inadequate respiratory protection among healthcare workers. Third, there is an efficient TB DOTS referral system within the hospital where 100% referral rate is supposed to occur. And fourth, there are delays in diagnosis, treatment, and isolation, as was already mentioned. So these factors all contributed to an ongoing risk of TB transmission within the hospital. Given these infection control gaps that we identified, we recommended the following to the Hospital Infection Control Committee. First was to train healthcare providers to observe a higher index of suspicion of PTB for inpatients who are admitted with TB symptoms, and to include a TB symptoms checklist in the patient record sheets for first contact physicians. Maybe adapt the FAST strategy as was mentioned by our previous speaker. And then second is to implement a rapid notification system from the laboratory to the respective clinical areas for reporting of positive results in order to improve diagnosis, treatment, and isolation intervals. And this rapid notification system should cascade to immediately activate referrals to TB DOTS. And lastly, we recommended the improvement of isolation standards and addition of isolation rooms or isolation solutions to decrease the risk of nosocomial TB transmission. So this summarizes the recommendations we made to the Hospital Infection Control Committee and the hospital administration. We are hoping that these are going to be realized. And we are also hoping that the National TB Program of the Philippines will prioritize effective hospital infection control among its targets. Thank you very much for listening.
Thank you, Dr. Agustin. Next presentation is on fast implementation in Bangladesh.
Respected chairpersons, distinguished guests from different organizations from different countries, good afternoon, and I welcome you all to my presentation on first strategy to prevent tuberculosis and diabetes comorbidities and prevent tuberculosis transmission in congregate settings. We all know individuals with diabetes mellitus have greater risk to be affected by active tuberculosis, which is 2 to 3 times higher than the individuals who are not suffering from diabetes. In most instances, we have observed that active case finding approach is not being followed in the congregate settings, and which create greater risk to transmit the disease among the immunocompromised persons like diabetic patients. Most of the instances, patients themselves seek their health services from healthcare providers passively. First, which stands for finding TB cases actively, separating safely, and treating effectively. It is one of the most important components of the TB infection prevention and control, which prioritize early diagnosis and prompt initiation of effective treatment. First is the most important administrative TB infection control practices. Sorry. It is a hospital, tertiary level hospital situated in the capital of Bangladesh. It is responsible for management of large number of diabetic patients. This is titled as BARDEM, which stands for Bangladesh Institute of Research and Rehabilitation in Diabetes, Endocrine and Metabolic Disorder, having about 700 beds and having services for both inpatient and outpatient departments. And on an average, 1,000 diabetic patients seek their health services from this facility every day. Considering the burden of the patients and also the closed environment of the hospital, the project, that is Challenge TB, funded by USAID, with support from National Tuberculosis Control Program, planned to initiate first in 2015 in this facility. As a component of first implementation, the project need to organize multiple formal and informal meetings with the authorities of the facility to make them understand about the importance of the fast and also to incorporate the fast component in their own infection prevention control plan. And it was completely a participatory approach. Like, the project recruited very few number of healthcare staff, but most of the health staff responsible for fast was included from the institute itself. And the project guided the facility to incorporate few important TB screening questions in the routine diabetic tool, which is being used by the medical doctors at the outpatient departments while patient follow-up checking or during physical checkup. And also the project supported to develop leaflet which included the basic facts about TB and the drug-resistant TB, and supported for developing recording and the reporting mechanism as well. We can see in the picture the nurses of the facility are being oriented on TB and DM comorbidities. And the project need to organize different type of trainings and orientation sessions for the capacity building of the physicians, nurses, laboratory technicians, and other health staffs. In the upper pictures, we can see the assigned person for first, he is distributing leaflet among the waiting patients at the outpatient departments. And we can see here the patient burden in the outpatient departments, and it is a completely closed environment. There is no system, there is no facility for cross ventilation. And this is the counseling session for the diagnosed diabetic patients, and in this picture, the assigned person for first, he is interviewing one patient at the indoor to screen TB or DRTB. So the first approach was provided both for the outpatient and the inpatient departments. Whenever the TB presumptives were identified, instantly their samples were undergo for the microscopy and the gene expert testing. And whenever the MTB positive patients or drug-resistant TB patients detected, they are referred to the DOT centers, which is situated in this hospital, to enroll and to initiate promptly the effective treatment as per NTP policy. So through the intervention, we can see in the result that from July 2015 to June 2016, 38,523 diabetic patients were screened, and among them, 1,425 patients were identified as presumptives, TB presumptives. Among them, 182 were detected at MTB positive, and we can see here that the 11 patients were detected as REF resistant. So the total number of the MTB positive and the RRTB detected was 193, that means 13.5%. So in that case, we can share with you that if we failed to detect these 193 hidden cases, then these number of the patients could be the source to transmit the TB bacilli among other immunocompromised persons like diabetes patients or among the family members and friends. This is the same results, where we can see the MTB positive was 182 and the REF patient register detected as 11. So in the conclusion, we can say simple minimal systemic alteration in the congregate settings can expedite and improve the care of TB, diabetic mellitus comorbidities, and at the same time, simple facility-based policy changes like active screening for presumptive TB cases facilitate early identification and prompt initiation of effective treatment for both TB and the DRTB patients, which can minimize the spread of TB among the high-risk population, among the high-risk healthcare facilities. Thank you very much, and thank you all. And I should acknowledge National Tuberculosis Control Program, USAID, Challenge TB, WHO, IRD, for conducting this type of study. Thank you very much.
Thank you, Dr. Jahan. And the next presentation will be dedicated to regional.
Good afternoon, ladies and gentlemen. My name is Biniam Fallaka. I work on TB HIV programs for CDC Ethiopia. So I'm happy to share with you the experience from the pilot project, TB infection control project, that is implemented in Redwa, Ethiopia, from November 2015 to 2016. Just to give you a little bit of background. So Ethiopia is among the high burden country for TB, HIV, and MDR TB. The incidence and mortality of TB is 192 and 25 per 100,000 population, respectively. And even though TB infection control has been recognized as key strategy, TB control strategy by the National TB Program, even to date, the TB infection control implementation at national level is assessed to be suboptimal. And the different national TB program reviews have shown that TB infection control is among the key program challenge for the Ethiopian TB program. In 2014, there was a national level TB program assessment, and in that assessment, it was found that nearly 1/3 of the health facilities do not have a TBIC plan, and most of the TBIC committees were not doing active monitoring of the TBIC as their respective facilities. So our project is implemented in Redwa. Redwa is one of the two city administrations located in the eastern part of Ethiopia, this tiny red labeled city administration. The Redwa administration have notified more than 1,600 TB cases and around 38 rifampicin-resistant cases in the year 2015 alone. And the Regional Health Bureau has also done a rapid assessment before the implementation of the project, and they have found that the incidence of TB among the healthcare workers in the Redwa administration was 40% higher as compared to the general population. So the name of our project is Building and Strengthening Infection Control Strategies, in short, TB Basics. And this is a global initiative originated from CDC HQ. Even the generic protocol we have adopted from the CDC protocol. And it is designed for assisting countries with high TB burden, HIV burden, in assessing, improving, and scaling TB infection control. And the objectives of the project are developing rapid and robust TBIC assessment tools, designing tailored TB infection control intervention packages, developing effective MNE+, which also includes healthcare worker screen surveillance indicators, and answering key programmatic and operational research questions. Basically, we have also adopted the same objective also for our project. The main intervention for this strategy is training and capacity building of both the program and the TBIC team of the facilities. So when you see the implementation framework, it involves making in-depth assessment as the health facilities and to identify most important TB infection control gaps. So we use information from the assessment as an input for our facility-specific intervention planning, prioritizing activities tailored to the facility-specific needs. And we move to implementation together with ongoing monitoring of the implementation. And then, we repeat the in-depth assessment at a certain interval, and the cycle continues like that in a continuous quality improvement model. So the implementation started as of 2015. The preparation, the first thing we have done was engaging the national and the regional program staff. We have different consultative meetings to solicit their opinions about the generic protocol. And then jointly we have visited the sites and reviewed the facility data over the years. And finally we have identified 10 high client load facilities out of the total 17 facilities in the city administration to be involved in this pilot project. And we have jointly adopted the protocol for the country context, and we have obtained approval both locally and from CDC. As you can see, during the baseline assessment time, most of the facilities that we have visited have congested waiting areas and corridors, and ventilation was very poor, and there was really high risk of TB transmission. So the implementation started in November 2015 with training activities. This is our main intervention for this strategy. A total of 72 health care workers and program staff have been trained into rounds, and we have printed and distributed the TB basics assessment tools, job aids, health education materials to all facilities. And baseline assessment was done together with the trained TBIC team. And immediately the feedbacks have been submitted to the facilities in color-coded dashboard. Technical assistance have been given for facility-specific TBIC planning, and the TBIC team went to implement the package of TB infection interventions tailored to their facility-specific needs in accordance with the national guideline. And the Regional Health Bureau provided ongoing mentorship and supportive supervision support, and the TB-IC team of each of the facility were conducting regular bi-monthly monitoring, self-monitoring of their TB infection control as their respective facilities. So in addition to the baseline assessment, we have done comprehensive TB-IC assessment at midterm and final at 6 months and 12 months. And for this, we have used a 45-item tool that we have adopted from the generic TB-IC protocol, and which also includes indicators for managerial, administrative, and environmental and PPE TB-IC measures. Composite scores tabulated to quantify TB infection control performance or adherence across all the TB-IC domains and specific facility areas or departments. So for infection control measures which are not implemented, we gave 0 score. For measures partially implemented, 1 point, and measures fully implemented, 2 scores are given. And adherence in terms of percentage was calculated from observed points out of the total possible points, and adherence performance at baseline was compared with performance at 12 months using chi-square test. So this is a dashboard that is prepared for regional level monitoring, and the 10 facilities here are designated by numbers 1 to 10, and the scoring is given in color, color code. So green shows meaning measures are available, yellow in progress, and red not available. So as you can see that the TB infection control situation was substandard at baseline, and it has improved over midterm and final evaluation period. This table shows baseline and final evaluation compares the final performance, and you can see by all measures for general OPDs, TB clinics, and facility-wide assessment, all have shown improved, and the changes are statistically significant. So out of the lessons learned, engagement of program staff was really key for achieving program ownership. The progress in establishing occupational safety-related TB infection controls was significant, and the acceptance was very high. And the use of this color-coded dashboard was very easy to understand, to visualize the performance. And the success demonstrated in our project was also more or less similar with the other countries implemented similar TB basics approach, and we believe that this approach is pretty well working in other sub-Saharan countries as well. The limitation we have is that some of the parameters are too much subjective, and the experience we have in this urban setting may not be really replicable, especially when we move in the scale up in some of the rural health facilities. So in conclusion, the TB basics approach has been demonstrated to be feasible and successful strategy, and the TB basics approach have improved institutional capacity for regular TB-IC monitoring, and the TB basics team will recommend this approach for national scale up, and we will be finalizing immediately after this the full evaluation report, and we'll continue monitoring, and we'll conduct 1 year post-pilot phase evaluation immediately after, next month. So, thank you. I would like to acknowledge all these colleagues and stakeholders. Thank you very much.
Thank you very much. Can we have the presenters sit in front so we can ask a few questions directly to them? Can we have a second microphone to go around? Anyone with a question, kindly lift your hand and then the microphone will come to you. You can go down.
You can use this one?
Yeah.
Thank you. So, just a comment. I particularly like this last talk and the fact that they had an evaluation plan and a timeline, and we'll continue to evaluate the program to see if it's sustainable. into the future. So my comment is that some of the other talks presented pilot studies and suggested that their technique or their approach could be replicated in other institutions. I would suggest that they also make an evaluation and monitoring plan and implement that if they continue their program or expand it to other institutions. Thank you.
Thank you for the comment.
Are there more questions?
Also for the other setting.
Hello?
Are there more questions to other presenters? Actually, I have a question to Dr. Gabunia. And you told about the implementation of FAST and it was based in general hospitals. Where this laboratory is located, which use GenExpert? Does it work?
Thanks. If it's working.
Hello?
Thanks, that's very important question. Actually, we've installed GenExperts at existing labs at private hospitals. So it was fully integrated into existing structures. We've trained lab technicians there in sputum collection and then doing GenExpert testing. And once GenExpert was once TB was confirmed with positive GenExpert testings, and immediately results were transferred into the national TB program, because actually all these things like private hospitals, FAST strategy happened beyond the national TB program. This was not like part of the national TB program efforts. That was donor funded, and that was kind of a private initiative based like intervention. And but right now, just to get back to another comment related to sustainability, the important outcome of this initiative was that the national TB program and National Center for Disease Control and Public Health now recognized FAST as a national strategy for infection control plus TB case finding in general healthcare settings. And now we have GenExperts installed at 57 out of 40 out of 54 district level general hospitals to make sure that we have a kind of a good nationwide coverage and have GenExpert as a point of diagnostics for that settings. They do not initiate treatment. That's why we need, once TB is confirmed, we immediately link patient to a national TB program, and the national TB program specialists, they take care of patients. So they prescribe treatment and provide follow-up.
Ed? Paul has the mic.
Okay. Paul Jensen, I'm with CDC out of Atlanta in the United States, and I thank all the presenters for great presentations. And what I've seen is a lot of process indicators. And my question is, for future studies, how will you help us quantitate or at least qualitatively assess the less transmission or some kind of a health outcome?
Also? So we've heard, and we'll hear a couple more FAST initiatives, and my question is, and it could have been said, and I easily could have not heard it with the noise we were dealing with, but I'm interested in the kind of cough monitors that are being employed, where they come from. Are they, trained, or are they people on staff who are asked to do more?
Thank you for all the presentations. My question is that, as in Mozambique, the TB, the problem on diagnosis of TB mainly is caused for limited working hours of TB laboratories. So I want to know if you or your TB laboratories are working 24 hours a day, 7 days a week. Thank you.
Our personal experience in the Philippines is that the TB lab is only open during office hours, and the sputum specimens taken during non-office hours will be processed the next day. And there are times when our personnel are at leave or on break, so there are delays in terms of diagnosis, processing of specimens.
So I would like to also respond to Paul Jensen's questions about quality indicators. Well, definitely most of the indicators are process indicators, but in terms of quality, what we'll be looking in our project is that, how many times have the TBIC team have done self-TBIC monitoring activities, and how frequent are they using the data that they are getting to really revise their TBIC plans. We also have some kind of outcome indicators we'll be looking over time. This is seeing reduction of TB incidence among healthcare workers. This might require several years of observation, and these are what we'd like to see as an indicator.
Last question, and then.
I am from Bangladesh. I am just representing Dr. Kausri Jahan. So, from answer to your query, that is the existing hospital staff that we already shown in the super specialty hospital, that is the burden. The existing hospital staffs are being trained on FAST. No new staff was being recruited or has been recruited on to implement the FAST. So the capacity build up on FAST is going on, and we are continuing this program in this Bardem hospital. Thank you.
Thank you very much. Thank you very much. We'll continue with the next set of presentations. We'll ask Dr. Wang from Beijing, China. Yeah. Thank you.
Now, good afternoon, everybody here. My name is Wang Xiuhua. I'm from China. I'm the director of nursing of Beijing Test Hospital.
Hello, technical people, can you please change the presentation? We have the wrong one. Thank you. No. Survey on knowledge and use of ultraviolet light. And kindly reset the timer for us. Reset the timer. Thank you.
Thank you. I'm very glad to have the opportunity to be here to this forum. My topic of my presentation is survey on knowledge and use of ultraviolet germicidal air disinfection among tuberculosis nurses in China. Now look at the lights. China has one of the highest number of tuberculosis and multi-drug resistant TB cases globally. TB cases in China is 920,000 in 2015. Now, TB infection control work is very important to reduce the risk of transmission of TB in hospitals. Germicidal ultraviolet light is the most common air disinfection method in China. This study aimed to understand the knowledge and the use of GUV air disinfection among tuberculosis nurses to provide evidence to develop effective tuberculosis infection control. In my study, TB nurses working in 26 hospitals in 20 provinces across China were asked to complete a survey, and the data were collected between February and April 2017. The questionnaire consists of 3 parts. Demographics include age, working years, position, and so on. The knowledge of GUV air disinfection, including 9 items. The use of GUV air disinfection, including 13 items. There are 396 nurses working in TB wards respond to the survey. The average knowledge score of GUV was 64.5%. The nurses had less knowledge on correct level of radiation, usage time, and installation, proper number for the space, and appropriate height. Just like the red words on the lights. From the slides, we can know the score is increased with age. Working years in TB wards, professional, title, and position. There are differences in the knowledge score between different ages, working years in TB, professional, title, and position. The older nurses have more knowledge than the younger nurse. The nurses working in TB longer had better knowledge than those working less time. Now let's look working in TB wards, professional, title, and position. The score is increasing with these items. In terms of practice, 88.4% of TB wards measure the radiation intensity at least every 6 months. 75.8% of TB nurses receive training of GUV air disinfection. 72.2% of TB nurses clean the ultraviolet lamps every week. 68.7% of TB wards, the exposure time of ultraviolet lamp is not less than 20 minutes, 30 minutes. 66.7% of TB wards measure the microorganisms in air every month, and only 22.7% of TB nurses replace ultraviolet lamps correctly. Now look at the conclusions. The overall DUV air disinfection knowledge among TB nurses in China is weak. Medical institutions should strengthen the training and education for nurses, especially focus on new nurses. We should strengthen the management and evaluation of DUV air disinfection to reduce the risk of transmission of TB and MRTB in hospitals. Here, I would like to thank the people who contribute to the research, especially thank you for Dr. Kaiser Tudor, she here. Thank you very much. Thank you for listening.
From Nigeria. Yeah.
Good afternoon, everyone. My name is Miguel Tilisboa from Mozambique, Portuguese-speaking country, so please pay attention. I'm going to talk about the feasibility and acceptability of cough officer, having cough officer, hospital cough officer, and 24 hours working of TB laboratory.
The presentation. Yeah, that one.
Yeah. Sure. This was a pilot start as we are finished it last month to implement an implementation research, which was to assess the contribution of a hospital-based cough officer and 24 hours working of TB laboratory. So before implementing the start, we carried out a pilot start in order to assess the acceptability and the feasibility of that intervention. The start was implemented in Mozambique. There is a big hospital, this is a central hospital in Beira, which is the largest second city in Mozambique. So initially, what we did, or at least the background of Mozambique, it is very important to say that the incidence rate in Mozambique, it is 550, yeah, and the city that we are carrying the start, in Beira city, it is above the national level. I mean, 600 cases. And the TB co-infection, HIV TB infection, at national level, it is 51. In Beira city, it is 69%. I mean, in Beira or in Mozambique, yeah.
Do you have your slides there? Just move them.
Oh, okay. I'm so sorry. That's why I was asking if you guys, your laboratory is always working in 24 hours, because in Mozambique it is just 7 hours. Even the TB treatment centers, I mean, if you got your diagnosis now, you can't get treatment. And imagine if you get your test on Friday, 12 o'clock, you must wait up to next Monday. So, and in Beira City, there is just documented that the health services delays in Beira, it's estimated in 62 days as a medium. Yeah, nosocomio TB in Beira, in that hospital, basically, is not well known, but we have data that at least 40 health care workers last year had a TB among medical doctors and nurses. So Mozambique, this is a very important point, has adopted the WHO policy on TB infection control and also has designed on national policy. But availability of information on local sustainable strategies to implement the TBIC within the healthcare services are scarce. And we know that hospital delays on TB diagnosis and treatment still are being reported, not just in Beira Central Hospital, but national. Although we know that a cough officer have been documented even in Taiwan, in Zimbabwe, and in South Africa, is a very, very important strategy and associated with early TB diagnosis and treatment. But in Mozambique, we didn't have information about this intervention. So, as was mentioned, we got a financial support from DDR, WHO, and to assess an implementation research to assess is actually the contribution of a cough officer, hospital cough officer, and 24 hours working of TB laboratory. This is our theory of hospital cough officer. I want to say that differ very, very different from other cough officers has been implemented in Taiwan or in South Africa. So the objective was just to assess the acceptability and feasibility of having a hospital cough officer and a TB laboratory working 24 hours at Beira Central Hospital. Okay, justice was qualitative, sir, and our population was decision makers, program managers, physicians, lab technicians, nurses, and auxiliary workers. So a sample was proposed, and the data were collected using, focal discussion, group discussion, and in-depth interviews. The content analysis was done using Atlas TI version 7 for Windows. This is the socio-demographic attributes of the participants. So I want just to point out that more than 6% they have 4 or more years of experience on TB services. There were emerged 2 main themes. So the first one was a lack of health human resources, and the first question over here is actually who can be or must be a cough officer, and what can be done in order to implement the tasks of a cough officer. So the respondents all indicated the problem related to staff shortage, but also they were strong to recommend that should not be a nurse, but an auxiliary worker that must be carefully selected and treated, trained, And here are the quotes supporting this evidence, okay? I can just pick up here. Auxiliary workers have always been involved in a sputum sample collection and sending to the TB lab. What must be done is to select, train, and entrust and supervise them. They should act well for this task. The provision of any NAFI masks can motivate them to be in close contact with the TB patient and to work willingly.
You go 1 minute, just 1 minute.
Okay, and the second point is actually limited working of hours of TB lab, which is the point that there is no TB lab that perform tests for TB diagnosis after 3 p.m. So neither on weekends. So availability of 24 hours of the TB laboratory service is urgently needed. There is two courts supporting the evidence. Okay, and the conclusion is that hospital cough officer and 24 hours working of TB laboratory were considered by the interviews to be acceptable, feasible, and urgently needed. Yeah, for early detection and initiation of TB treatment, hospital authorities in Beira, in this case in Mozambique, may need to adopt and promote acceptable, affordable, and sustainable practices such as expanding working hours of TB laboratory and making available hospital-based cough officer. Thank you.
Thank you very much. So can we have Yang? Yes. And kindly put your questions together after this presentation.
Okay. Good afternoon. My name is Chidubem, and I'm here to present a case study on how fast a fast strategy can increase case detection in a health facility setting. Okay. So, Nigeria is one of the high burden countries in the world, and currently contributes about 6% of the global incidence. But the challenge that it faces is actually low case detection and late detection of TB cases. In 2015, the case detection is at 17% national level, and that is still the lowest among the high burden nations. The low case detection actually is due to the passive case finding that is adopted majorly in the country due to also the care scheme behavior of the citizens too. Now, Nigeria, like many other nations, actually open and in dire need of finding the missing cases. And Challenge TB implemented in collaboration with the National TB Program, a strategy, fast strategy, in one of the teaching hospitals in the country. This hospital is actually a high TB HIV reporting site and serves a population of over 200,000 people. Like some of the previous presenters has noted, fast is actually means finding, actively separating and treating. Is a strategy that hopes to halt the transmission of TB in health facilities. So the objective, we measured the contribution of fast strategy in detection of TB in that hospital. So the methods, we first conducted a mapping of the center, and after we mapped the service delivery areas, points that we are going to implement fast, we carried out advocacy to those units, and after that, we conducted sensitization of the staff of those selected service delivery points, and thereafter appointed some fast coordinators in different units of those facilities and cough monitors as well in those identified units. Then we instituted a cough surveillance across all the units that we are selected, and cough triaging continued or started, and patients were being fast-tracked to either to the doctor or to the laboratory, as the case may be. Then we followed up this implementation monthly by the state teams and the TBL supervisors at the local government level. So at the first 3 months of implementation, we realized that actually by implementing FAST in that facility, we increased the number of presumptive TB cases by 38% compared with the baseline, which was a quarter before the implementation. And we measured this with the same quarter, sorry, the same period in the previous year, and we noticed that that FAST contributed about 88% on the presumptive TB cases identified in that facility. Then in terms of TB cases, we realized that about 67 percent increase in TB cases detected in that facility. We are observed compared to the baseline, that's the previous quarter. And when we compared this as well with the previous same period in the previous year, we realized that we had about 35% increase in number of TB cases, all forms of TB cases. And the bacteriologically confirmed cases, we realized that we had over 100% increase in the baseline. And of course, as we did, comparing it with the previous year, same quarter, we realized we had about 54% increase in bacteriologically diagnosed TB cases. We also measured the time it takes, because FAST also intends to reduce time to diagnosis and treatment. So we measured the time it takes to confirm diagnosis and commencement of treatment in the same facility. So in the first 3 months, we realized that the time to diagnosis averagely are reduced, and also the time to treatment reduced. Mathematically, it amounted to 35% in the baseline, or approximately 36, and also 39% compared to the previous year. And when we looked at as that's based on diagnosis, and also for treatment, we realized that we had a 45% reduction in time it takes to confirm treatment. Okay, so as a word conclusion, we realized that FAST strategy can actually improve TB case dictation rapidly in health facility setting, and of course reduce time to diagnosis and time to treatment in the facilities. So FAST as an infection control strategy could also contribute to case detection, increase in case detection in our facilities, especially in settings where the case detection is low. And we applaud the ongoing expansion of FAST strategy in the country by the National TB Program, that it is actually a good step in the right direction in finding the missing TB cases in Nigeria. Thank you so much.
Thank you very much. Can we have Miguel?
I'm now doing research at Yale University, and so it's my pleasure to present our work on internal migration and transmission of TB in Shanghai, China. And we have our main collaborators from Fudan University in Shanghai. So I give a brief introduction about the internal migration in China. As you know, because of the economic boom in China, and it has drawn rural Chinese move to urban cities in search of high incomes and jobs. And the population size grows rapidly, and it's now account almost 20% of total population, which is like 250 million in 2050. And however, because of the household system, migrants have significant restriction to access to the same service as the local residents in urban areas, and such as health insurance and social security welfares. And it's difficult for them and unlikely for them to shift their status, and they are, because of many aspects, they are more vulnerable to communicable disease like HIV and TB. So as you know, China is also one of the high TB burden countries, and those massive internal migration from rural areas with high TB prevalence to urban areas with low TB prevalence has been associated with the increased notification TB in urban areas, and there are many studies regarding to the risk factor of TB infection care among migrants, but until now there's no study addressing the role of migrants played in the transmission dynamics of the in the local scale. So for example, whether these cases are from importation or local transmitted. So our goal is to use genomic and spatial and epidemiological data and analyze to investigate the transmission of TB and in the urban areas in Shanghai. And our start setting located at the Shanghai, Shenzhen district in Shanghai, and with about 1.8 million population, and as I said, migrants increased from 0.6 to 1.2, and at the same time, the residents kept steady as 1.6, and it's ongoing prospect population-based study, and since 2009, include all the culture-positive TB patients. So the method we use, first we use questionnaire interview to collect baseline information, also epidemiological information, as well as the GPS coordinates, which is the current residential areas when they get diagnosed. And also to understand the transmission, we use genotyping followed by whole genome sequencing to do class analysis among MTB strains. We also infer the transmission dynamics, use different strategy like the reconstruction, the possible transmission network, and use a regression model to test the association between spatial and genetic distance. Also, we will estimate the infection time. So this study includes about 1,600 TB patients, and you can see a majority of them are from migrants, and migrants shows different characters compared to residents, like more female and significantly younger. Majority of them were labor worker, and most of them are new cases. So if we look at instance spatial distribution of instance among this district, you will find there's a area with highest instance, and almost all the patients are from migrants. And if you look at the spatial distribution patterns of the TB cases among migrants and residents, they are quite distinct. Not surprisingly, it's in agreement with the overall distribution of population. So we did class analysis. Because of the ability to infer transmission dynamics, we only include those clusters, VNTR clusters, with class size of at least 3 patients, and finally we got 150 were in genomic cluster, which means they are recently transmitted. And if we look at different class type, we found that resident-only class type actually had larger genetic distance compared to class that involved migrants, which means this transmission may happen remote and involve some local circulated strains. So one of the important questions is that whether this transmission among migrants occurred after or before their arrivals in Shanghai. So we used 2 methods to answer this question. First, we just simply examine the province of origin of these migrants and found that 84% of them actually immigrate from different origin province, which means unlikely they are transmitted before they arrive. And furthermore, we use a Bayesian approach based on time-labeled phylogeny tree, which use genomic data to estimate to determine the transmission direction and also capture the infection time and compare to the arrival time. So we were able to find that almost 80% were infected after their arrivals. It is similar to that one, and we also find that this proportion is similar among migrants from same originate or from different originates. So finally, we were able to combine these informations. For example, we constructed the possible transmission network using genomic data and epidemiological links. In this figure, you will find there's very few epidemiological links you can identify, but and there's no links between migrants and residents. But if you look at the genetic distance, you will find that the distance between migrants and residents among mixed clusters are very small, say like 0 to 1 SNPs, and compared to the larger genetic distance you can find from among resident-only clusters or migrants. They are from the same province. Also, we add the special links to those clusters, and you can find you can find obviously spatial proximity among migrant-only residents or rest-only clusters. Sorry, and also there's the same phenomena exists among mixed clusters, but we also observed among some mixed clusters, the migrants actually live different community compared to the cluster of residents, which means they have may imply some causal contacts, or we missed some transmission links for this transmission chain. Sorry, maybe the number you cannot see clearly. And I just showed a cluster of at least 4 patients, but actually the pattern is similar among patients with 3 or 2. We also did overall analyze to test the association between spatial and genetic. Actually, they show significant association, and also we do sensitive tests, like use different genetic distance to define the genomic clusters, and actually that didn't change the result. So summary, we able to show that the influx of the internal migrants actually contribute to the increased TB transmission in this urban area in China, and it's not solely due to the importation or reactivation from latent TB, but actually there's locally transmission between migrants and residents, and it's not uncommon. And the majority of the transmission among migrants occurred after their arrivals, and the transmission was significantly associated with spatial proximity. And we were able to say that more common and promote active case finding strategies are needed to ensure early detection of TB among migrants, to provide treatment to interrupt and minimize the transmission. Also, I mean, they need to apply similar strategy among the residents, but migrants is a priority. So thanks for all the collaborators and the funding sources, and thank you for your time and questions.
Thank you very much. So can we have the presenters sit in front, and then can we have a microphone go around for questions? Any questions? Yeah, okay.
I have a question for the presentation from China on ultraviolet. Actually, 2 questions. One is, are these upper room germicidal fixtures designed to be in occupied rooms, or is this the style of UV that is used in some parts of the world where they're turned off when the room is occupied? That's one question. And you mentioned measuring TB in the air monthly. I wonder how you do that.
3 questions, and then we'll take answers.
Very confusing when you do that. It's hard to get the continuity.
All right. Okay. Can we have a respond?
Okay.
First, I've answered the second questions. Measure the intensity of ultraviolet light. We can use a monitor. monitor, and the monitor will give the intensity of the light.
一个问题，就是他的意思是每天24个小时能开，或者每个星期
I see. Now the first question is because we use various kinds of ultraviolet light. One kind of is we can open it all the time with the people under the light, and other fond of ultraviolet light. The people, when the people working and in the room, they can not open the whole day. Yeah, thank you very much.
Thank you. My question is to the last presentation. It's about, I think one, because there's lots of information. My question is, one is that how you actually decided that there is 78% of the migrants who were transmitted of TB when they arrived, after they arrived in Shanghai. So there's some kind of thing. My second question regarding, because we are, the study was looking at a district in Shanghai. And while the city is very big, lots of migrants can go from one part of the city to another part of the city. And so how would you, distill that? Because you would miss something who has been a transmitter but left from the district you were studying with.
Thank you for the question. Actually, it's a very good question, especially the second one. So I'm going to answer the first one. It's regarding to the how we determine the whether they are transmitted arrive before or after they arrive. So actually, the second method we use we based on the genomic data and the time they have a symptom or the time they get diagnosed to and they use a Bayesian approach to estimate the distribution of the possible infection time, and also we have questionnaires. So we collect their arrival time or their arrival time period, because sometimes they just give you a period. So you're right. Like many of them actually didn't give us clear message whether before or after. They actually overlap to each other, but we just use those have clear message to say like 78%, and we also using the original province, like I showed, like 84% of the migrants in the same cluster, they are actually from different provinces. So it's kind of this, like they are similar, and we believe the Bayesian method is kind of solid. Also, we admit like there's some uncertainty. Yeah, that's for sure. And the second question is actually the limitation of the study. I didn't show the slides, but yeah, you're right. Like first, we didn't know like maybe some of migrants they were left Shanghai before even get diagnosed. It's hard to quantify that. And another issue you mentioned that they were travel to other part of Shanghai. I think because this district they have many factory and manufacturers there. Like most of Apple computer are from there. Like so they're doing this kind of work. So I think the kind of residential there when they arrive. So maybe the moment like two different part will be like kind of minimized due to this kind of because of it's an industrial park, many industrial park there, and at the same time it's hard to quantify. Yeah, it's one of the major limitations of our study. Yeah.
Thank you, Dr. Nan. Yeah.
I also had a question for Chang Guang about the transmission within Shanghai. Great study and excellent integration of different data sources. Did you see any evidence of the transmission networks within the new migrants feeding into the local residents? So, is there any evidence that by targeting migrants for screening that you could actually also improve the epidemic within the older residents of that district?
So thank you for the question. So our method actually able to determine the transmission direction, and we find like there's it's cross transmission. Migrants transmit to residents, and also residents kind of transmit to migrants. But still, like in the area with high incidence, and we can see that many migrants actually transmit to the infection to the other migrants, and this actually accounts for the major part of the transmission events. And we do observe the cross transmission, but it's like it's not the major part of it. And the residents transmit to residents is even lower. Yeah. So we can say like migrants involved most of the recent transmission we observed in this area, but it's hard to say like account for their transmission to residents. Yeah.
Thank you. My question is also for the Shanghai study, so don't run away. TB in your so-called floating population is a massive issue in China. And I'm wondering, have you used your data to look at some of the risk factors for these people? And have you thought about considering ways of reducing the transmission amongst the migrant population? I noticed that they were very clustered in certain geographical places, and I'm thinking to myself, are these dormitories? Are they properly ventilated? What about UV light? What about other interventions? Similarly, what medical services are available, given that the migrants do not have hukou for Shanghai? What do they have, and should it be improved?
Excellent question, thank you, and it's kind of tough to answer. So for the first one, because we need to obtain, we need to do sequencing, so we only include the culture positive. So actually, if you want to use geographic data to identify some risk factor for migrants, I think it's better to include all the TB cases. And the culture positive rate is now 30%, 30 in Shanghai. It's actually better. It's better than the other area in China, but it's not good enough. So I think it's a good question, and it's worth to answer. If we include all the migrants there and use their geographic data and do some analysis. And also you mentioned like, if there's like, you also notice that there's some hotspot for certain clusters. Actually, you're right, like some of the clusters, they are concentrated in some place, like there's some cheap rent house for them to live. And also there's a manufacturer, they will also provide dormitory for them, and I don't know if they have some like UV light to disinfect, like some kind of infection control for them, but I hope they have, but I cannot answer that question. But yeah, it's good for doing some infection control among them, and if we can also use the geographic data to inform those kind of like target intervention. And for the second questions, like you mean, if I understand correctly, you mean what is kind of medical service or health care for them? Okay, so one of my slides showed that since 2004, the Shanghai CDC expanded the free treatment to migrants, and before that, it's not available. Like it's not free. So right now, if you are a migrant, you have to do physical examination before you are able to illegally employed. And if you identify TB, most likely you need to start your treatment and you don't have the job. And if you already have the job, they will do like screen, but not so common. But if you find you have TB, I think the Shanghai CDC ask those manufacturers to ask them not to fire them and let them treatment, and after treatment, if they smell negative and culture negative, they will get back to work. But I don't know how this goes well or not. So still there's many barriers for them to seek care, or although the TB treatment is free, but they still have to afford other medical care, medical cost. But at least Shanghai has rich medical resource, and they kind of likely to cheat there.
Thank you very much for all the presentations. I think the key thing we want to see here, we've seen a lot of pilot interventions being presented, and I would want to encourage all the presenters to follow through with the work and present to us the scale-up versions of all their presentations next year. We actually want to see how your work is panning out, especially in the light of the fact that infection control activities are waning, and we are trying to increase the interest in infection control. Thank you all very much for coming, and hope to see you again.